know that they provide shock absorption, but it's usually a load and a shear that will clip off or tear meniscus. Femur usually is going to rotate internally, but it could go externally as well. And what you're going to see with meniscal tears, pain, a low grade effusion. So at the joint line, they're going to have some swelling and tenderness, especially after activity. Joint locking, I've experienced this, no fun. Springy infield in certain ones, decreased weight bearing tolerance, yeah, it can unlock itself. You can passively manipulate that. Don't worry about all that so much. It's just managing the acute symptoms, then treating the impairments. It's going to be painful, but not terribly painful. Okay? Yeah.
Okay, so I think I asked you this like last semester or something, but why is it because of the mechanism of injury that the meniscus is always like a co-current injury?
Yes.
Because like,
yes.
It's always like, oh, I tore my ACL, but my meniscus was somewhere too.
Yeah, I mean, so we got to think about what happens with these. If I move this tail out of the way. So if we're going to tear the ACL, we know that that's got to come forward and probably twist. It's the twist part that nicks some of this stuff. Okay, so it, again, load shifts and all this kind of thing. There's all kinds of stuff that's going to recreate that. So again, here's our red area, which has blood flow. Pink area has limited blood flow, and the white area is relatively avascular, so it's not going to heal if this occurs in here, okay? So what they can do, there's a lot of different options, and I've had 3 of these meniscectomies, partial meniscectomies. So these take out the bad part. So let me just do this better than I can draw. You just go down to one of these. It shows. All right, you see here meniscal tears, and a little bit small. But along the outside here, you get a little flake off on the inside. This is a bucket handle, and this is the one I had. So a bucket handle tear occurs on the inside in the avascular area, and it flips over. Within the joint, it flips over, and it ends up locking the joint. I mean, you cannot move. I hit first base, and it was like someone shot me. I got about 2 more steps, hit the ground, and crawled back to first base, could not move my knee. Okay? It spontaneously unlocked, but the damage was done at that point. So they can go in here and they can buff these things up and just make them as pretty as they can. That's the meniscectomy part, partial meniscectomy. Or they can repair. Now, repairing a meniscus, again, we've got to be in this zone for it to repair, to actually repair itself, or through sutures. They can go in. Now, you guys, it's good you're sitting over there, because these guys, the younger ones, they are probably candidates for a meniscal repair, okay? When you get above about the age of 40 or so, that's when they say, we're just gonna take it out. We're just gonna trim it up, okay? But a meniscal repair, when they suture these things down, this is when you might see somebody non-weight bearing for 4 weeks, 6 weeks, okay, depending. Because what they don't want is loading to occur with any shearing, right? But again, mostly young folks. The oldest I saw a 43-year-old guy who had a meniscal repair, and he did great, and he was non-compliant as hell. I mean, I kept telling him, he would walk into the clinic. I'm like, what are you doing? You were supposed to be non-weight bearing. Oh, I feel great. I said, of course you feel great. Idiot. Insurance agent of mine, good guy, really good guy, but he didn't listen to the damn thing. And he turned out fine. He said, as long as I don't twist, I'm all right. I said, what about non-weight bearing? Do you not understand? Typical non-compliance. All right, so maximum protection phase, 4 weeks, range of motion, isometrics, ankle pumps, patellar mobilization. That's all you can do for 4 weeks with these people. If they are repairs, if they are Meniscectomies, you can go at it, it's just kind of like that subacromial decompression of the shoulder. Nothing's been repaired, you get after it. But if this, again, if this is a meniscus repair, this is what you're gonna see. And they will be in a brace. She didn't wear it. And they will have weight bearing restrictions, which she didn't follow. Moderate protection phase from 4 to 12 weeks. You get rid of the brace at 6 to 8, and you can start doing a little bit of strengthening and so forth. Weight bearing, but again, still no shearing, still no twisting, still no turning. When you get past that, that's when you can start getting back to it. And he was a triathlete. He was trying to get back to competition and all this stuff. I'm like, you should have just got rid of it. But why do they try to preserve the meniscus? It helps with all that stuff, weight bearing, shear forces, all that cushioning. So they try to save it when they can. Right? Because you know, if you get a bunch of this meniscus taken out, that you're gonna have a knee like mine that doesn't have a lot of shock absorption, and it's got a lot of osteoarthritis at that point. Does that make sense? Partial meniscectomy, get after it, people. Just do what you can. So I had 2 of these. I had 3 actually, but 2 in particular. One of these, this is how time depends on the amount of tissue taken out and the premorbid state and everything. So after my sophomore year at Auburn, it was in the fall. It was after fall season. I had surgery on, like, I want to say December 1st. I could have played 10 days later. All they took out was a bit about the size of half of my pinky nail. It was just an irritant to the joint. I was in great shape. I could have played within 2 weeks easily. But then they did this again. It was a larger piece, more concurrent injury. Probably took me about 6 weeks at that point. So again, that's going to be totally variable on the athlete or the patient or what's going on there. But I usually tell people, if they come in to therapy after partial meniscectomy, and you hear people say a scope knee, arthroscopy, scope knee, I usually tell them 4 to 6 weeks, and you're probably going to be in pretty good shape, just to be on the conservative side. But for the most part, these people do really, really well. Because again, nothing's being repaired. There's no sutures in there. We're not waiting on any time frame there. We just go as we can. Now we know there's healing that occurs, and sometimes that can be a little bit painful. But again, what are you looking for in this functional progression? They've got to have full range of motion. They need to be evolving in their strength and in their endurance, both muscle and cardiopulmonary. You start doing balance and proprioceptive activities, perturbation training. What is perturbation training? We'll practice all this afternoon, but anybody know what that is, perturbation training? Stand on one foot, throw a ball, or try to push me, and they're trying to balance and hold themselves in place. Okay. Plyometrics and agility drills, what are those? Jumping, box jumps, agility's changing direction, like you put the little ladder down, jump in and out of it, all kinds of different stuff. And then we talked about simulated work-related activities and sport-specific types of stuff. So we want to make sure that we, again, if you're dealing with an athletic population, you've got to get them back to their sport. So tell me, let's use a wide receiver in football. What do they need to be able to do? Let's start from easiest to more advanced. What's the easiest task that they have to do on a football field? Run a straight line. Okay? Run a straight line. So this is where you're going to start. Run that straight line. If they can do that, then what do we go to? Start changing direction. Do we want to start with real hard, sharp cuts? No. Start running in circles a little bit. Then you get to the hard, sharp cuts. What else do they need to be able to do?
Turning.
Catch a ball, but we're talking about lower half stuff.
Stop and go backwards.
Decelerate, oh, that's a big one, decelerate, huge. Teach them how to slow their body down. How about jump? That's what I was trying to get at. Being able to jump and then land. You gotta teach them how to do that stuff. Okay? That's our job. That's our job. You gotta take a task and break it down. A wide receiver's gotta do all of those different things. Okay? Let's take a hockey player. Anybody watch hockey last night? What's a hockey player have to do? Skate.
Constantly bending at the knee.
Start with skating a straight line first. Then you start skating in circles. Then you start cutting. Okay? They got to be able to jump and stuff too. It's crazy what they have to do. Amazing. Amazing athletes. Volleyball player. What do they have to be able to do? Jump is big, right? Change in direction. Got to be able to go to their knees, right?
Know how to do it.
Yep.
Landing.
Yep. So you got to break these things down. Don't forget about doing that. Okay? Don't just take an athlete and say, "Oh, you've got perfect range. You've got great strength. You can run for miles. Blah blah blah. You're ready to go." And they're not. They're not. You got to take them, put them on their field, put them in their setting, and start on those specific things that make up what they do. Okay? You are doing them a disservice if you don't do that. All right. So that is the end of knee. So let's just do a quick little look at lab so you'll know what to expect this afternoon. You need to have your game on. We get into some fun stuff here. Before we do that though, let's look at here. Look at all the stuff we got here. Here's total hip precautions, okay? This is a patient education thing. This is written for patients. So you definitely better know all this. And if you want to flunk a practical, that's an easy way to do it. Is not know hip precautions. Knee lecture, lab, ACL protocol. Again, don't memorize this because they're all going to be a little bit different. But this is a really, really good breakdown. Talks about, again, this is designed for a patient. But if you know this and you can explain this to them, you'd be in good shape. Talks about precautions. All right, so there's a couple other procedures. Meniscus repair we talked about, allograft, ACL, microfracture. Anybody heard of that before? Controversy whether that really is a really good thing or not. So we know that where there's blue, whoops, I think we got a permanent dislocation. Where there's blue, what is that representative of? What kind of cartilage? No, not fibro, because that's what this is. Articular cartilage. Okay, so it's the shiny part on the bone that allows it to move nice and smoothly. Okay, fibrocartilage is thick. Okay, so articular cartilage. If we see somebody, especially if we're dealing with an athletic population who starts to have wearing of this articular cartilage, there's a procedure called microfracture. Basically, they go in here and they just drill holes into the damaged tissue. Why would they do that? Because it's going to kind of trying to jumpstart the healing process and generate more of this articular cartilage. Okay, so this is usually a non-weight bearing thing. This is kind of similar to the meniscal repair. So microfracture you will see occasionally. There's a lot of controversy on whether it really is effective or not. in theory, it makes a lot of sense. In practical sense, it just doesn't always work.
But do those patients come in for like another surgery? Or you just-
Unfortunately, they do. They shouldn't, but a lot of times they do.
You would die, they were in a lot of pain usually, with the leg and cartilage.
Oh, you can imagine. Yeah, they're just gonna drilling holes in your.
But like prior to, like.
Yeah.
They don't really have much sign other than.
It's just like beginning osteoarthritis, if you think of it. Yeah. All right. So this Oates procedure. There's a bunch of these. Oates. It's the one that they wanted to do on me. Macy was the one they wanted to do on me. Oates procedure. So my right knee, which was my good knee, is no longer my good knee. So I have, and we don't even know how this happened. I have on my lateral femoral condyle, I have a divot taken out of my bone. It's about 2 centimeters. It's pretty good size, almost an inch. Divot taken out. The most pain I've ever been in my life. I slipped, it probably happened this way. I was walking down a hill and just slipped on like some pine straw or something like that. And really didn't do anything. But the next day my knee swelled big time, and I'm telling you, if I bent my knee past 90 degrees, it was like someone took a knife and just stuck it right in there. I mean, it would bring tears to my eyes every time I would do it. So I got an MRI, and my doctor, because I thought I'd torn some cartilage again or something. Get the MRI, and doctor calls me and he says, well, you got what they call an osteochondral defect, OCD. He goes, I want to do this procedure on you. This was 10 years ago. I want to do this procedure on you where I take good articular cartilage from the opposite side, and I send it to a lab in Boston, and they grow it based on the specifications of the lesion that you have over here, and then we take that from Boston and we put it in here and we plug it. And I'm like, okay, sounds wonderful. What has to happen after that? He says, well, then you're 6 weeks non-weight bearing. I'm like, 6 weeks non-weight bearing. I asked him, I said, are you gonna pay for the divorce that I'm gonna have? Because I'm not gonna be able to help around the house. I mean, with my son, my wife, she couldn't do all the things that he does. So I decided not to have that procedure. I haven't had anything. I've done nothing. I haven't had a scope, anything with this. I've gotten, I think 2, maybe 3 injections, and I no longer run, and I no longer squat past 90 degrees. And if I do those things, I'm okay. I still swell and all those types of things, but I can manage because I can still do elliptical, I can still ride a bicycle, can't run, I can walk. But elliptical and bike is how I, get my cardiovascular and keep myself in somewhat form of shape. But I cannot run anymore, which I used to love to do. But that's the price you pay. Because if I go run, I tried to run on this was miserable. My knees swelled like you can't believe. But I'm too old to have that procedure now. There's no way they would do that. It's gotta be somebody young, kind of like the meniscectomy or the meniscal repair. Very similar. But these Oates and Macy, you don't need to worry about these, but these are just the abbreviation. They got something kind of crazy mnemonic for these. These are the types of things that you'll see. And then there's another one too that's pretty popular. But these are all biologics, they call them, where they take your cells and they make them better. They take them and grow them up in that lab in Boston, and that plug comes back and then you would put that in that spot. So you're gonna see those from time to time. So those are another one where you're gonna see where you have to restrict weight bearing, okay? That's when you do a lot of, what would we do to keep my quad in shape for that? Lots of rushing, lots of rushing. What else? Yeah, that's probably about it on those procedures. Let's look here. I'll chondromalacia protocol, that's basically just saying don't let them sit, don't do anything in a bent knee position. Meniscectomy protocol is basically nothing, just get after it more than anything. The total rehab we talked about, and here's the ACL protocol from Stanford. Where's this when he was at Wake? This might have been when he was at Wake. But again, this is my doctor that's very detailed. You can see, look at the exercises he's prescribing. On day number 15, he wants you to edit. Very specific, very specific. Now, did I follow these to a T all the time? No, because you make clinical decisions. But it's nice to have protocols that are this specific. I'd rather have one that's more specific than one that's not, to be honest with you. But you'll notice here is the all exercises in the first 3 to 4 weeks are done in the brace because what? The sucker's dying off right as we go. Yeah, this is the ACL. Anyway, very, very specific. Don't memorize it. Just have it at hand and take a look at it and understand it. That's about that. All right, so get ready for lab. We will have. Get ready to move. We'll go through all these. It'll be fun. We'll start with manual. We'll start with hip stuff. Going down to the knee, and then we'll do exercise. It'll be fun. Be ready to go at 1 o'clock.